Good evening, everyone. Welcome to this amazing webinar tonight. Here we are with Brett Hawes. He's going to do tonight's webinar on gut infections in clinical practice. So this is to be very enlightening. I'm sure many of you already know Brett by the sounds of it, and I sure know him. He was my first teacher in January of 2018. And boy, he got me engaged. That's one thing about Brett is when you are talking, everyone is listening, which is it's a big gift. So I am just going to tell you a little bit about Brett. Brett is a 2006 IHN graduate, and in 2016, he was certified in functional medicine through Functional Medicine University in the US. He started his home-based practice just before graduating in 2006, helping people with basic issues like weight loss, energy, and digestive issues. Now, Brett, weren't you working in Ayurveda exclusively at the time?
I was, and I got fully captured and enamored with Ayurveda. And I know you're super into Ayurveda as well. You're studying it right now. Yeah, in the beginning, a lot of it, was almost all exclusively Ayurveda and then holistic nutrition. And then as time went on, I started realizing that Ayurveda is its own thing, right? And not everyone was looking for that. And so I kind of just branched out and kept adding stuff in, and fast forward to today, functional medicine, clinical nutrition. I do still draw on Ayurveda quite a bit when I need to,
Yeah.
It's a fantastic tool for just, when you look at someone, when you look at their lifestyle, when you look at their body shape, when you look at the foods they're eating from an energetic perspective, I find, and also from a soft diagnostic perspective, Ayurveda works really, really well.
Absolutely. I agree. So a little bit more about Brett is he has done extensive work with First Nations and studied shamanic medicine. Brett has helped thousands of clients overcome a wide variety of health issues in his 16 years of clinical practice. He runs a cloud-based online clinic with his primary focus being chronic and complex digestive issues, hormone health, and autoimmune disease. He has been part of our in-class faculty in Toronto and Mississauga campuses of IHN for 14 years, teaching nutrition and health, the fundamentals, as well as nutrition and the environment. And recently, he launched IHN's online program, Teaching Fundamentals. Brett also mentors graduating students as a student clinic advisor. His popular weekly podcast, Holistic Health Masterclass, is ranked in the top 200 alternative health podcasts in the world and reaches thousands of listeners in 57 countries each week. That's amazing. So Brett is here tonight to share his fabulous information, which is like a little bit of a snapshot and information on his upcoming continuing education course, which is Digestive Health Practitioner Masterclass. So Brett, it's all for you.
Cool. All right. Well, thank you so much for that introduction. That was lovely. Thank you. I always get a little squirrely when people read out the long bio, right? I'm like, okay, let's just get to it. There's lots of good information to share. I
shortened it.
It's all good. It's all good. What I would like to do is just share my screen and hopefully everyone can see that. You can see that, Anna? Yeah? Okay, awesome. All right. And I want to see if I can get some faces up here. Okay, cool. So welcome to tonight's presentation, Gut Infections in Clinical Practice. What I'm going to do is actually scooch right forward here because Anna did a fantastic job. I'll quickly plug the podcast, Holistic Health Masterclass podcast. You can find that pretty much all over the place. And if there's one thing I'm not consistent with, it's releasing podcasts. And that's because it is a pure labor of love at this point. And I get to speak to some really cool people when I'm on it, right? In addition to everything else, I do want to just make quick mention that I have worked with a number of different supplement companies in a variety of different roles, whether it be, mostly product education, consulting, formulations, and that sort of stuff. And then worked with a couple of organizations down below, like the Detox Project and the NHPPA, which have a little bit more to do with, quasi-activist stuff. Well, actually not quasi-activist, actual activist stuff. And then of course, IHN, which how most of you know me. So what I want to cover tonight is, and I'm going to do my best to get this in an hour. I actually thought I had an hour and a half when I announced this, and lo and behold, it was an hour. So we'll probably land up somewhere in between there. So we're going to cover exploring the microbiome, how poor digestion leads to gut infections, dysbiotic patterns of various types of gut infections. So we'll dig into some of that. Challenges and limitations of functional lab testing. Functional lab testing is all the rage these days. And I want to share with you perhaps a different way of thinking about lab testing and not just going on these huge fishing expeditions to kind of have a look-see. Comprehensive stool testing, SIBO testing, and organic acids testing. Obviously, I don't have time to get into the nitty-gritty of it all, but nonetheless, we're going to talk about those today. We'll talk about biofilms and some novel approaches to using antimicrobials, prebiotics, and probiotics. And we'll kind of wrap that up with a very, very simple framework for you to help people with gut infections. Just to give you something to shoot for and some structure. Okay, so I want to know from you, what is the microbiome? I ask this question quite frequently, and I'm curious to know what people think the microbiome is. And you can just drop that in the chat box if you want. Anything, and you don't need to be embarrassed if you don't know, or if you think you know and you get it wrong. Okay. All right, so we've got some answers coming in. So the environment of bacteria, viruses, parasites living within us. Sure. Yeah, I like that. Gut bacteria. Okay. So that's what a lot of people say, right? Bugs in our guts, gut bacteria. Okay. Gut microflora. All right, cool. So here's really, when I think of the microbiome, right, I think of the organisms that live in and on us. And what we've really done over the last while is we've sort of expanded at least I have anyway, I've expanded the way that I look at the microbiome. And we actually have multiple microbiomes within our larger microbiome, which is us in our entirety. And you can see here, these are just a few. You can see that there's an oral microbiome, so that would be dental. There's actually respiratory as well, and the sinuses. We've got the gut microbiome, obviously, which is what most people have said. We've got skin microbiome, right? Vaginal microbiome, and we actually have a microbiome in the placenta as well. So more on that in just a minute. And what you'll see, and I think that most of you know this already, what we're discovering is the vast interaction of the microbiome in all of its forms with other things that are seemingly unrelated. So you can see on the left-hand side of my screen, the gut microbiome being involved with obesity, metabolic syndrome, colorectal cancer, all sorts of other stuff. And you can see the skin microbiome there as well. So if we want to just sort of zoom in a little bit more, some interesting facts here. And we'll just start on the top right-hand side. 90% of your microbiome, so we're just going to talk about microbiome as a general, right? 90% of the microbiome is made up of bacteria. Yes, we have fungi, yeast, we got viruses. We'll talk more about parasites in a minute. But we actually have more bacterial DNA in and on us than we actually do cells in our body, right? So cellular DNA. And they outnumber us by about 10 to 1. But the crazy thing is that if you had to put them all together and pop them on a scale, they only weigh 4 pounds. Right? But the implications are so huge that once you start working with the microbiome, and obviously the focus of this presentation is really looking at the gut microbiota. But as many of you know, working on the gut microbiome will have crazy impacts on other areas of health that are often unrelated, or they appear to be unrelated. Okay, so and again, this is very rudimentary, so we're going to sort of start high level and then go a little deeper. We have a combination of quote unquote good guys and bad guys, right? So on the good side of things, they perform a variety of functions, some of which we'll cover in just a minute. But essentially, there's a symbiotic relationship between the good organisms and us, the host. And then, of course, we have quote unquote bad guys. And I don't even like to use the word bad. I prefer to use opportunistic. Okay, because I think it's more correct. And people often wonder, why do we have 10 to 15% of the bad organisms in and on us? And there's a number of points to pull out, right? The first one is, the obvious one is they actually are there to keep everything else in check. So as much as we've got good organisms to keep the bad guys in check, we've also got the bad guys to kind of exercise and flex our immune system. Our immune system can identify these. I mean, I always say, can you imagine if your immune system had never ever seen Candida before? Literally a minor yeast infection could potentially be fatal. So we have these organisms that are opportunistic, that are normal inhabitants. And the problem really becomes when they get overgrown, and or when our beneficial flora become depleted for whatever reason. Okay, we'll expand on a lot of this as we move forward. So our microbiome is really made up of all of these, and we just said that. So normal or common cell bacteria, opportunistic bacteria, fungi, yeast, viruses. And I think there's still some debate with regards to parasites, right? So consider that more than 50% of the world, right? So people in the world have at least one parasite. And sometimes what we'll see on stool testing is they will show up, they'll be detected, but they're not out of range and they're not causing any problems or symptoms. So I think there's debate as to, are parasites a natural part of our microbiome? Are they true pathogens or exclusively pathogens? And I think the jury's still out to lunch on that one. But 90% of our gut microbiome is made up of these normal or common cell bacteria and then these opportunistic bacteria. And we'll take a look at that in just a second. So the highest variety of strains, right? So we've got all these different organisms that live inside the gut. The highest variety, or the most numerous strains that we've identified, are around 300. Some of the older research, which is a little bit outdated, sort of identified 1,000. There were some mistakes there. And some of the newer research suggests up to 500. Okay, so I'm just going to say, I don't think we really know, and we haven't pegged it down. And of course, we're discovering new strains all the time. So the point being is that when you look at some of the more advanced stool tests, they're kind of looking at around the 300, 350 mark, somewhere around there. Okay, so most healthy adults, if you look at the general population who are asymptomatic, who don't have any pressing illnesses or diagnosed conditions and whatnot, they have around 125 to 200 strains. Okay. Ideally, what we would want to be is as high as possible. So we want to be around the 200 mark. And if you're somewhere between 250 to 300, you're somewhat of a unicorn. Okay. I've yet to see someone as high as 300 in the tests that I've done. Now, what's interesting is when you look at populations like the lost tribes of the Amazon, for example, or the Hawes, which are the last true hunter-gatherers from East Africa in the Tanzanian region, they've actually done quite detailed analyses on their microbiome. And it turns out that they have between 50 and 100 extra additional strains that we here in the West don't have. And I think that some of the reasons why is obviously they're eating a pure whole foods diet. They're living very close to the land. I mean, they're on the land. No antibiotics, no chemicals in the food. Their stress levels are not absent, but they're quite different from ours, and the pace of living and all that sort of stuff. And lo and behold, when you look at the Hawes, for example, bowel conditions and bowel cancer and stuff like that is virtually unheard of over there, which is quite interesting. Okay. So bacteria also differ from small intestine to large intestine or colon. You'll find that there are certain strains that are quite low in the small intestine, and when you get to the colon, they're quite high, and vice versa. We also find that the esophageal microbiome, so that's the tube that connects the mouth and the stomach, you'll find that there's similar bacteria that are there, and then also in the small intestine, right? So there's some relationship there as well. So the four main phyla of the human microbiome are Bacteroidetes, Firmicutes, Actinobacteria, Proteobacteria, and then there are a few others as well. Okay. Again, I'm not going to go super deep into any of this stuff tonight because I really want to get to the good stuff. But it's important for us to sort of understand where we're at. And what's really cool is with a lot of the new tests, we can actually see these, and we can go beyond the level of phyla. We can really get quite granular with all of this. And I think it's a very exciting time for functional lab testing and for gut health in general, because how many people do you see in your clinic where people just come in with, gas and bloating, right? And it's like, okay, well, what's going on, right? How do you approach that? And with, the advancements in stool testing, we can really, really dial into what's causing problems in that particular person. So For the longest time, we actually thought that the placenta and the womb was completely sterile, right? And I think a lot of people still believe that. I would say that it's relatively sterile. A lot of the new sort of research has shown that there are high levels of certain bacteria, but the number of bacteria is quite low. So there's not a lot of variety there. Okay. Obviously, baby receives mother's microbes as it enters the birth canal, which does raise the question, what is this doing to or what is the impact of cesarean sections? Considering that last time I checked, I think it was about 30 or 35% of women are opting for C-sections now. And I think that, we've yet to see what the long-term implications are with regards to offspring's microbiome, okay, especially in the long run. Of course, as babies nursing and so forth, and later through food, we will the microbiome will be further populated. This is, obviously 100% going to be governed by the mother's microbe and her own microbiome health at that point. And as we get older, development continues to be governed by diet and environment. But here's the kicker. New research suggests that the microbiome is relatively fixed after the age of 3. Okay, I want to just linger on that point for a minute. There's a lot of debate about this. So can the microbiome be altered after the age of 3? And I think there's a more nuanced answer, right? Because the microbiome is relatively fixed. In other words, if you're giving your child lots of antibiotics in infancy, maybe processed foods, not enough fiber, right, and so forth, that is going to alter the microbiome. But here's the thing, and this is where I say the nuanced side of things comes in. What newer research is showing is that we can temporarily modify the microbiome. Okay, that can be in a positive way with prebiotics, with probiotics, with diets, right, lifestyle, and so forth. But it can also work in the other way. And I think of things like low-dose antibiotics in the food. I think of things like glyphosate and Roundup exposure, stress, processed food, sugars, all of these types of things. So I think that if we had to have a magic wand and we could say, hey, let's just remove everything from the outside and let the microbiome sort of settle to where it is, you'll probably find that it's relatively fixed after the age of 3. Okay, fantastic book for those of you who want to read it and geek out a bit is a book called Missing Microbes by Martin Blaser. Okay, so really, really good book. And he talks a lot about this, right? Really flips a lot of things on its head when it comes to the microbiome. So moving on, and I've sort of alluded to this already, the microbiome influences many, many body processes. And I think that we are just scratching the surface right now. Okay, we obviously know about digestion. So, the absorption or digestion of food, particularly things like lactose, for example, and our lactic bacteria, but it helps to digest all other food compounds as well. Nutrient synthesis, this is a huge, huge area these days, is actually looking at the bacteria themselves and seeing, are they actually sufficiently synthesizing my B vitamins, my vitamin K, my short-chain fatty acids, which are fuel for the intestinal or the colonic cells. And what's really cool is we actually have tests now where we can kind of start getting insight into this. And of course, we have to wonder what the impacts are of repeated antibiotic exposure and so forth. Gut barrier function, again, I think we're all familiar with leaky guts, but the repeated insults to the gut barrier and the depletion of our microbiome really paves the way for leaky gut and for many other associated health conditions. Immunity, I don't have to tell you, 70% of your immune system is in your gut, largely policed and moderated by the microbiome itself. Neurotransmitter synthesis and metabolism, things like dopamine, serotonin, melatonin, GABA, all of these, we find, for example, 400 times more melatonin in the gut than the brain. Okay, which is phenomenal. The majority of the serotonin is manufactured and synthesized in the gut as well. Okay, and so on and so forth. Gut-brain function. Okay, so mood and brain function ties in with neurotransmitters, but we also now understand that we've got the superhighway called the vagus nerve, which is one of our cranial nerves, and this really connects via the enteric nervous system, not just to our gut, but in fact to all of our internal organs. So anytime there's stuff going on up, maybe with our mood or stress levels or anything, that's going to have a direct impact on our gut, and vice versa, right? If there's anything going on in the gut, it's going to affect our mood and brain function and so forth. And this is why, you only have to look at something like Candida. The number one symptom for Candida is brain fog, right? Everyone with Candida will tell you they have brain fog. General metabolic function. We now have identified certain strains that are very, very tightly correlated with things like obesity, metabolic syndrome, right, diabetes, and so forth, which is really the next point here. So hypoglycemia, diabetes, prediabetes, and all, and that sort of wheelhouse. And I think this is really a short list. This is just really the high level things that we are certain of. But I think that some of the probiotic companies I've worked with in Asia, they have patented strains that have been shown to influence bone health, right, and things like osteoporosis and so forth. Okay, so very exciting. And I think, again, we're just scratching the surface with all of this. So what I'd like to do is just move us along here. So poor digestion, the microbiome and infections. When we look at digestion, really it's just one-way traffic. I'm not going to rehash all of this, but essentially food goes in the top and it comes out the bottom. And if there's something going wrong at the top, for example, I'm not chewing my food properly, or I've got chronic bacterial infections in the oral cavity, so that could be a root canal, something like that. That right there is going to impact everything else going down. So, for example, not chewing my food properly or eating too much or anything like that is going to tax the stomach. If the stomach is taxed, that's going to tax the gallbladder, it's going to tax the pancreas, then the small intestine, and the large intestine, and everything below that. All right. So again, just in the interest of time, I want to just share some points here on this. Low stomach acid is a huge, huge factor with all of this, right? In addition to digesting proteins mostly and a little bit of fat, stomach acid sterilizes pathogens. And so you can imagine if for whatever reason, if it's stress, if it's eating the wrong foods, nutrient deficiencies, what have you, if I'm not producing enough stomach acid, pathogens are not going to be sterilized. And that means that pathogens that would normally not enter the gut take up residence, right? And then we can feed them with certain types of foods. The other consequence of low stomach acid is that it doesn't trigger the pancreas and the gallbladder. If we don't trigger the pancreas, we have low enzyme output. Okay, there's many other reasons why this can happen, but low enzyme output basically means that I don't break down my food properly. If I don't break down my food properly, I'm going to have larger food particles that will land up where they're not supposed to be. And guess who finishes the job? Microbes. Right. So now we're feeding microbes with undigested food particles, and they start to grow and they start to suppress our beneficial flora. Okay. Now this is a huge one, right? The gallbladder. It's over the last few years, I've really come to appreciate a lot more the impact that poor bile flow and gallbladder flow really has. Poor bile flow, when we think of bile, usually what we think of is we think of fat digestion, right? And that's what most people would say. So bile equals fat digestion, end of conversation. Well, it turns out that bile is a very, very potent antimicrobial. And so if we are not getting regular bile flow, we've actually lost a branch of our antibiotic effect or antimicrobial effect. Also, bile is a mild laxative. So it keeps the bowels moving. And if the bowels, of course, are not moving, you're going to land up with constipation. And constipation can then equal dysbiosis or bacterial imbalance. The last thing that bile does is it's also an alkalinizing agent. All right. So it affects the pH of the gut. Right. And of course, we know that if the pH is off, what's going to happen is that's going to create a favorable environment to host pathogens and other organisms. Okay. All of this to say, the ultimate outcome can, in many cases anyway, it results in damage to the gut lining, which then paves the way for leaky gut, autoimmune diseases, food allergies, et cetera, right? And so much more. Okay. This right here is the root cause of, autoimmune disease. That's what I work with a lot in clinic. And you would be amazed at the impact of digestion and infections that they have on autoimmune diseases. Okay? And consequently, working on those makes a huge impact in terms of getting good results with your clients. So let's talk about some dysbiotic patterns here. And again, we'll just do some high-level overview. So the first one I want to talk about is IBS and SIBO. Okay, for those of you who don't know what SIBO is, small intestinal bacterial overgrowth. And the reason why I've lumped that together with IBS or irritable bowel syndrome is because it turns out that the majority, or I would say well more than half of people with IBS suffer from SIBO as well. Okay, and a lot of the IBS symptoms are directly related to SIBO itself. Okay, so some of the patterns you're going to see, people are going to react to high FODMAP foods. The big ones here, if I was to highlight anything, garlic, onions are huge. A lot of the beans are huge. Dairy, so the lactose there. And so when you're speaking with people, it's usually a good idea, you know, when people say, oh, I got food sensitivities, I always like to go, okay, well, let's just talk about that a little bit more. Which foods are they? And what does that reaction look like? Because with this type of person, the reaction that they're going to have is most likely going to be gas, bloating, abdominal pain within a very, very short time of eating these types of foods, right? The word FODMAP, the acronym, actually stands for fermentable. Okay, so fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. And so the question is always, what is doing the fermenting? And it turns out that it's certain types of bacteria, right? Now with SIBO, you can have methane predominant SIBO, you can have hydrogen predominant SIBO, you can have hydrogen sulfide. So, there is some nuance there as well. But nonetheless, people are going to react to these foods. And in severe cases, they're going to react to most things on this list as well. Okay. Now, if you did a food sensitivity test, you're probably not going to find too much. Right? So removing the foods is going to make a huge difference with these people. So getting IBS following a bout of acute GI infection, this would be things like traveler's diarrhea, for example, which would result in post-infectious IBS and SIBO. Temporary improvement in IBS symptoms after taking antibiotics. I've had so many people that will say to me, yeah, I went to the doctor, I had something else going on, they gave me antibiotics, and boy, all of my GI issues started getting better. Right. And then they got better for a while. The SIBO came back because the relapse rates are crazy high on SIBO, as little as 3 weeks. And then everything came back, more antibiotics, back, forth. Okay, so very common thing there. And interesting here, a worsening of IBS symptoms from ingesting probiotics. Okay, so how many people out there taking probiotics with the best of intentions, prebiotics, okay, such as FOS or fructo oligosaccharide? Well, sounds a little bit like FODMAP, right? Fermentable oligosaccharide. So a lot of these prebiotic and probiotic supplements will really re-aggravate people with SIBO, because really what you're talking about is the small intestine is filled with bacteria and you're throwing more bacteria on there, okay? And the last one here, eating more fiber increases constipation and other IBS symptoms. Right. So this is a pattern here. What you'll find is not everyone is going to check off all of these boxes, but they typically check off quite a lot. In our masterclass, we actually have full checklists for all the stuff. It's about 19 to 21 questions that can really help you before you've done any lab testing, that can really help you to sort of identify, does this person have SIBO? Does this person have IBS? And you can kind of go down that road. Okay. So let's talk a little bit about Candida. Okay, I don't have a separate slide for that. I'm just going to speak to that. The obvious ones for Candida, people are going to tell you that sugar, okay, they just cannot handle sugar at all. Your bready stuff, so all your baked goods, okay, yeasted products, that could include, obviously things like beer, wine, any kind of alcohol, all right? But I also have heard a lot, and I've seen this is again as another pattern. I've seen that people oftentimes are very, very sensitive to cheese. Okay. And I think it has something to do with the molds in the cheese, right? They also tend to be quite sensitive to red wine specifically. Okay. And by extension, other sulfite products. And the reason for that is simple. When you look at candida, the metabolic byproducts, right, the main one being aldehyde, that basically has to get detoxified through the liver, and sulfites go down the same pathway, right? Alcohol goes down the same pathway. So this is why you find a lot of times people, when they're sensitive to all those things, it's usually that their liver has just been processing so much candida over the years, and their barrel is just full to the top. They cannot handle anymore. Okay, very, very sensitive to alcohol, these people. Bacterial dysbiosis, again, that's very, very general. You're going to find that for most people, with all of these for that matter, gas, bloating, abdominal pain, okay, pretty much goes with all of them. You'll find bacterial dysbiosis generally, there's no clear patterns, but people usually say gas, bloating, abdominal pain, and they react to more of the carbohydrate type foods, right? So anytime they eat sugar or simple carbs, that's what causes the gas and bloating and so forth. Okay. Now, when it comes to parasites, okay, parasites are very, very enigmatic. There's no clear patterns aside from the ones that I've highlighted here on the slide deck. So chronic diarrhea is often a very big clue. And what you'll find is people have tried things like fiber from the pharmaceutical side of things. They might have tried things like Imodium, right? They might have tried Saccharomyces boulardii, which is very good for traveler's diarrhea, and to no avail, right? So they just haven't got anywhere. Constipation, skin bumps or rashes, right? Unexplained weight loss is another one, coupled with increased appetite. So these are people that will tell you they have an insatiable appetite. It doesn't matter how much they eat. They just cannot put on weight. Oftentimes, when you do testing, you'll find that there is, in fact, leaky gut along with that. And then they have abdominal pain and cramping, which is very important here, unrelated to food. Okay, this is a big differentiator between parasites and the others. The others, you've got, all gas and bloating. Okay, not all, but I would say 90% of gas and bloating is directly related to microbial activity. Okay, this here, because those microbes are feeding on the carbs, on the sugar, on whatever it is, and they are fermenting them and causing gas and bloating, right? Parasites are different. Okay, they will steal iron, they will steal copper, right? This is why you see anemia down there, a little bit lower on the list, but it's not a cause and effect, right? It's not like you eat a food and then you have these symptoms. It's very, very erratic. It's very elusive. It's all over the place. And when you hear those words from people, they say, I just can't put two and two together, start thinking about parasites. All right. So vomiting in very severe cases, obviously, joint and muscle aches, another common one, sleeping problems, anemia, and general aches and pains. So this brings into question here, what about food sensitivities and allergies? Okay. Because when you start getting into all of this, it can be very difficult, right? So how can you tell the difference between a food sensitivity, an allergy, and an intolerance versus a GI infection? Okay. Once again, I defer to testing. Usually what you're going to find is, given what I've just discussed over the last 10 minutes or so, you're going to find that if it's infections, they're going to react to certain types of foods, right? So the best example there is those FODMAP foods with regards to SIBO. What you're going to find with sensitivities and allergies and so forth is they're not going to be grouped together like that, right? Especially someone with leaky gut. It's going to be total shotgun when you look at the food sensitivity report, right? It's going to be all over the place. All right, so just be aware of that. Sometimes it is bona fide food sensitivities and there is an immunological component there. But I usually like to test that down the line. My first protocol is to usually go, well, if we're looking at the gut, let's do some testing. Let's look at the microbial makeup. Let's tweak the diet according to that. And then we can sort of worry about food sensitivities and allergies a little bit later down the line, especially if we hit a wall, okay, and we plateau. All right, so let's hop into some functional lab tests and some general points of consideration here before we jump into the specifics. I want to be quite clear because this really trips a lot of nutritionists up, especially functional lab tests are not diagnostic tests. Okay, very, very important. There's this hesitation, am I stepping outside a scope? Like I'm not allowed to diagnose people. We are not diagnosing people at all. Okay, I will not and cannot and legally cannot diagnose people. Functional lab tests and functional nutrition or functional medicine, the whole the name itself means that we are running tests to evaluate function. And then we're employing natural remedies, lifestyle, supplements, diet, etc., to restore function. So I always explain it to people, the medical profession is running tests to diagnose disease. I'm running tests to figure out why you have that disease. Okay, so why do you have what you have from a metabolic standpoint? Some other things to consider is why test, right? Why do you want to test? And more importantly, what are you testing for? I've had clients come to me that have spent $10,000, $15,000 on lab tests, and I can tell you 2/3, sometimes 3/4 of them, garbage, right? I'm like, you didn't need to run this. So when you're running tests, why test, first of all? A test gives you an objective report, okay, as opposed to you just working off symptoms and going on hunches. Right? Not that symptomology is not important, right? It's very important, but a test is an objective scientific report. What are you testing for? This is really ties in with the next few points. So running tests that are necessary and running tests that are going to give you good actionable data to work off. Okay. Sometimes we want to run tests to rule things in or rule things out. But I usually, because functional lab testing is expensive, I usually like to say to people, based on your symptomology, based on your lifestyle, your health history, and so forth, I think that these tests will give us the most or the best data. And that way, when we work on that data, we can actually see those translate into results for you and improvements. Okay. And second last point, a test is only as good as the person interpreting it. Okay. So it's great to have all this data in front of us, but if we don't know how to interpret it properly, we're not going to be able to put the correct plan of action into place. All right. So, but you have to start somewhere, right? I remember the first time I ran some of these tests, many hours going over them, right? Because I didn't fully understand what I was looking at. And the more you do it, the more you see it, the more patterns you see, the easier it becomes, right? And highly, highly valuable. Last point here, master symptomology, okay, or symptomatology. Don't throw symptoms out the window. Okay, I see a lot of people now that are treating the labs. Okay, they treat the labs, they run a lab test and they just treat the lab. From a holistic perspective, I want to look at your symptoms. I want to look at lifestyle, the whole health history, then choose the appropriate lab tests and put all of that together. And once you do that, that's where the magic really happens, right? Because now we can use symptomology to actually track our progress. Okay. I worked without lab tests for 10 years. Okay, give or take. And then once I started bringing the lab tests in, wow, everything just started really getting better and better and better. Okay. So some advantages and limitations here. Obviously, you have to run the right test depending on what you're looking for. Okay, running the wrong test, not going to give you the right data. Important to note that no test is 100% accurate. Okay, and that goes for any test out there, whether it's allopathic, whether it's functional, it doesn't really matter. None of them are 100% accurate. I'm a huge fan of running tests that have broad spectrum biomarkers versus narrow testing. Okay. And to bring that into point here, or into focus, we want to get a gauge on overall gut health versus isolated infections. So the amount of people that come and see me and they'll say, oh, I did a stool test with my doctor. They tested for 2 parasites or 1 parasite. I'm like, well, let's zoom right out. Let's test for 80 or 100 or 120 biomarkers on 1 test. And let's see how we go from there. Because now what we can do is we can evaluate the whole environment and we can look at some of the relationships between these different things. All right. So very important there. There's major limitations for the small intestine. An endoscopy only gets the first third of the small intestine, and a colonoscopy doesn't really do anything at all. It only looks at the colon. So this is why we rely on things like organic acid testing and breath testing. Okay, for the small intestine. And that kind of ties in with the one here as well. Same thing with a stool test, right? A stool test doesn't tell you that much about what's going on in the small intestine, save for a few biomarkers, and vice versa. The small intestine testing doesn't show you what's going on in the colon. Okay. Now, as you get more advanced in this and you get more comfortable with reading some of these tests, you can definitely draw some pretty good conclusions. And again, when you tie in the symptomology with that, you can definitely start really getting quite good at straddling both of those lines. Okay. But you didn't hear that from me. All right. So As far as comprehensive digestive stool testing goes, these are the ones I use. This is probably the ones I use the most. GI Map from Diagnostic Solutions, the CDSA from Great Plains. I don't use that as much anymore. And the Biome Effects, which is a newer test from Microbiome Labs, really, really cutting edge test. Quite different from any other stool test out there on the market. And we'll talk more about that in just a second. So organic acids testing, the OMX, which is another test from Diagnostic Solutions, and the organic acids test from Great Plains. I tend to use both of those quite evenly. I'm a lot more comfortable with the Great Plains test because it's been around for longer. And I think in the functional medicine space, you'll find that most people gravitate towards that. Okay. And then SIBO testing, SIBO Clinic Canada, which is great. You don't need a requisition for that. And then there's also SIBO testing from Genova Diagnostics as well. Okay. This is a very, very short list. These are the ones that I tend to gravitate towards the most. But of course, depending on the situation, there's all sorts of niche tests that we can run based on what's going on with the person. All right, so let's have a look at some of these data points. And again, I don't want to belabor this just in the interest of time here. So the reason why I like comprehensive digestive stool testing is because we can look at all of these different biomarkers, right? So bacteria, yeast, fungal, and viral markers, parasites, worms, amoeba, digestion and absorption markers, inflammation. Okay, very, very useful for when you're working with someone with Crohn's or ulcerative colitis or leaky gut for that matter. It's great to be able to track inflammation. Immunology. So looking at things like secretory IgA, how is your intestinal immunity functioning? Is it hyperactive? Is it hypoactive? And why? Intestinal health generally, leaky gut. And what's really cool is on some of these tests, you can actually see sensitivity to antimicrobials and antibiotics. And of course, then conversely, you can detect whether any of these organisms are resistant to certain drugs and antibiotics. Okay. How cool is that, right? That you can actually run a test. Can you imagine this person? They've tried all these things that are natural. They've tried all these antibiotics, and you run a stool test, and lo and behold, there's only one thing that's going to work. Okay, that happened to me with someone where the only thing that was going to work for the infections that they had was grapefruit seed extract. That was it. Right? Pretty wild. And of course, when you move forward with that, the needle starts to move, which is great. So this is what some of them look like if you've never seen them before. Again, I'm not going to decipher all of this and interpret it, but basically what you'll have on the left there is you will have these expected and beneficial flora. So these are the quote unquote good guys. You'll have your common cell bacterial flora here in the middle, and then the dysbiotic on the right-hand side. All right. And then what we'll see moving further down is testing for yeast, okay, for candida, and so forth. Sometimes you'll see on the bottom left there where it says microscopic yeast, you'll see that nothing has come up in the culture and they have detected some microscopic yeast. And again, if the person's showing all the signs and symptoms of candida, it's not a bad idea to embark on some sort of treatment regimen. Again, these are just looking at protozoa, nematodes, so different worms and stuff like that. Okay, same thing over here, right? Again, I'm just trying to give you a sense of what you can expect when you look at these. That's all. Okay, we're not trying to interpret anything tonight. So this is from the CDSA from Great Plains lab. And what they do is, as I said before, they actually will culture certain bacteria, yeast, and so forth, and then challenge them with all of these natural and prescriptive agents and see what is going to be the most effective. You can see in this particular instance here on the top of the screen, you can see that caprylic acid, grapefruit seed extract, and silver to a lesser degree would be the choice for, I think this is Klebsiella bacteria over here. All right. So this is straight from the GI map. right? And you can see they actually list opportunistic bacteria right on the top. So additional dysbiotic or overgrowth bacteria. You can see here potential autoimmune triggers. Okay, so this is actually taken directly from my clinic files, by the way. So this is what I see on a regular basis. And when you see reports like this, the first time you see it, you're like, oh my gosh, where do I start? Right? What do I do? How do I break the cycle? And it can be quite overwhelming, right? So we'll talk a little bit more about some of these patterns and relationships a little bit later on. Okay. What's really neat about the GI map, by the way, this is the most, I would say it's the best pathogen screen on the market. In addition to giving you a yes, no, so out of range or within range, it also is a quantitative measure. So it can tell you how out of range that is. And that's what you can see, for example, here. If you look at this Proteus bacteria, you'll see it's 2.35 to the power of 6, where the range should be 1 to the power of 3 or below. So this particular bacteria is very, very high, and it could be a potential autoimmune trigger, right? So very useful for people that do have autoimmune issues. You can kind of put some pieces together there. Okay, multiple different types of fungi and yeast tested on the GI map. Okay, you can see protozoa, worms, and so forth. Now, I just want to ask you, I mean, can you imagine what's the difference between having this kind of data and not having it? Right? Huge, right? Huge. Because how many people out there don't have this data? They don't want to spend money on testing. They haven't thought about it. But boy, they've probably spent tens of thousands of dollars on different types of cleanses and supplements and antimicrobials and probiotics, and they haven't got any traction at all. Once you start understanding how to use these properly in practice, all of a sudden your focus and the way that you do it becomes laser focused and with absolute precision, that you are in a much better position to get results with your clients. So this is the Biome Effects dashboard. Okay, so as I said, this is a very different test. This is technically a functional analysis of the microbiome. Okay, so it's got, yes, they test for pathogens. They will say straight up that it's not a diagnostic for pathogens at all. However, they test for a lot of pathogens, not as much as the GI map. But where this test shines is this looks at how your microbiome is functioning in your body. So, for example, we can see over here, if you look at functions, right, and this is cut off, but you can see saccharolytic fermentation. So how well am I fermenting my carbs? Because the bacteria feed on the carbs, right? That they ferment carbs in order to produce nutrients for us. And you can see here, these short-chain fatty acids, butyrate, propionate, acetate, okay, are all low. So this is a fantastic tool. We'll just start in the top right here. A gut microbiome index basically looks at all of these scores and adds them together. And anything over 30 is considered good to go. You'll never see anyone at 40. And this particular person here sitting at 20, they got a lot of stuff going on, right? The alpha diversity on the top here is really the variety of species. Okay, so we'll see that on the next slide. The variety of species, and then the beta diversity is the richness of those species. So how robust, what do their numbers look like, okay, and so forth. And you can see this particular person here, this is taken straight from a client of mine who has ulcerative colitis. You can see very, very low numbers on both the alpha and beta diversity, okay, which is a big, big red flag. We've got our resistome index over here, which tells us overall how resistant and how resilient is our microbiome. And then we've got this pathogen control index over here as well, which basically says, hey, what pathogens are out of range, what are they associated with, and so on and so forth. So this is basically following on from the last slide. You'll see, this is the number of species here, and you can see the healthy population here between around 125 to 200. This particular client here, I think they landed up around the 125 mark. Okay, so they're lower. They're quite low over there. I don't think, sorry, just to be clear, these slides don't, this here is not the same slide as this. Okay, you can see the beta diversity index is different. Okay, so I just lifted this from another client of mine. Now, this test gets very, very granular. You can get all into the phyla. You can get into all the different types of bacteria. You can see here on the top right, too high, too low, and the relationships between them. So all of this stuff means something, right, when you get into it. Okay. I'm going to leave it at that, and we'll come back to something in just a second. All right. So short end of the story here is stool testing gives you data that you can never, ever get from symptomology alone. Okay. It's impossible. When we talk about SIBO breath testing, as I said before, SIBO is small intestinal bacterial overgrowth. Okay, we're not talking about the colon, although you can detect some things from this test that are happening in the colon. But this is a small intestinal test, right? And using breath is the best way to do it. So the way the test works is your client or patient would drink a solution that is either glucose or lactulose. Okay, lactulose tends to be the best. All right. And they would drink the solution that will ultimately be fermented by the bacteria in the gut. Okay. So if those bacteria are there, i.e., if you have SIBO, they're going to ferment these liquid drinks and they're going to produce hydrogen and methane gas. Okay. One of the new tests now, it's just coming onto the market, has hydrogen sulfide as well, but most tests don't have hydrogen sulfide on there. And so from this, you can actually plot this on a graph and you can see what's going on. So breath testing measures the hydrogen and methane gas produced by organisms in the small intestine that is diffused into the blood, then the lungs for expiration. Hydrogen and methane are graphed over 2 or 3 hours. 3 hours is better, by the way, and then compared to a baseline. And clients or patients drink a sugar solution of glucose or lactulose after a 1 to 2 day prep diet. Okay, so this does require some effort on their part. It's not just a random spot test. You do have to prepare for that. So within the first 2 hours, if on a lactulose breath test, and again, we don't have to get granular here. Okay, I know it's a lot to take in, but hydrogen going over 20 parts per million, methane going over 12 parts per million, or combined over 15 parts per million will give you a positive on that test. Now, I'll just share a little bit of a clinical tip here that methane, even as low as 2 parts per million, can oftentimes cause the symptoms associated with that. So even though you might get a negative test, pay attention to the symptomology, and you might still have to treat that person for SIBO. Okay, the glucose breath test here, either gas is 12 parts per million. I'll just tell you this much, that a lactulose breath test is really the way to go. Okay, it's gold standard. So this is what it looks like. Again, we don't need to go over this in great detail. You can see at the bottom there, okay, this is a positive. And you can see on this test here, on the right-hand side for methane is at 6 parts per million. Okay. So again, if this person had symptoms, even at 6 parts per million, you might want to employ a SIBO protocol. You can see this one again, right? Now, I'll just say this much, that after 120 minutes, you're getting into the large intestine. Okay, so anything up to 90 minutes is happening in the small intestine. Anything over and above that is in the large intestine. All right. Now, what's cool is some of the stool tests, this is going back to the Biome Effects, you can sort of see what's going on. And here we can see that we have markers on a stool test. Now, I want to be very clear. Technically speaking, you cannot use a stool test to diagnose or analyze or detect SIBO. Okay, it's incorrect. However, if the person is reacting to those FODMAP foods, if they have all the signs and symptoms, and you start to see markers like hydrogen sulfide, like methane, right? Like here, like the phylomicrobiota on a GI map, if these are both high and they match all the other symptoms, you will often find that a SIBO protocol is going to work very, very well for that person. What's cool here is we also have this methanobacteria. Okay, once again, this is a new marker that GI Map has added to their test. And look at this, high, high, high. If I go back here, what have we got? We got the phylomicrobiota here is high as well. Okay, good chance this person has SIBO and dysbiosis in the colon. All right. So The organic acids test has major advantages as opposed to stool testing and SIBO testing. SIBO testing is really, really exclusive to SIBO itself. It doesn't test for anything else. The way that an organic acids test works, right, is anytime I want to convert A to B to C to D, I need enzymes, I need nutrients, okay, and so forth, to get me from A to D. Anytime I'm lacking those nutrients or there's microbes in the mix, they will block the conversion, and you're going to land up with these organic acids in the urine. Okay, the higher the organic acid, the more deficient someone might be, the higher the yeast might be, or what have you. Okay, so the organic acids test measures byproducts of microbial metabolism that are excreted in urine. Very, very key and very important because it can detect things that are outside of the stool, and it can show us a little bit more about what might be going on in the small intestine. So the amount of times that I've got a stool test back and the candida markers are absent, right? Everything is fine. And then I run an organic acids test, and lo and behold, the fungal and yeast markers are elevated. Now I know that I'm dealing with a case of SIFO, or small intestinal fungal overgrowth, which often accompanies SIBO. Okay, so huge. And in addition to all of that, because this is a broad spectrum test, you can also get insight into mitochondrial function, Krebs cycle neurotransmitters, certain vitamins, not as much minerals, but we can see if someone is deficient in vitamins, GI function, dysbiosis, and a bunch more. Detoxification, methylation, there's a bunch of things that you can glean from these types of tests. Okay. So this is what this looks like. You'll see at the top yeast and fungal markers. Anytime you see them in red here, okay, in the center is bang on. You know, that would be 100% even. This here is one standard deviation, and then this is 2. So the further you get away from these center lines, the more out of balance that is. And you can see this particular person, 1, 2, 3, and this one's creeping up as well. So this person has a lot of yeast and fungal issues going on in their small intestine. Okay, here we can see again yeast and fungal markers, but also different types of bacterial markers going on as well. All right, don't worry about the names, it's all quite sciencey. And we can even detect different types of Clostridia. Okay, Clostridia are huge and have such widespread effects. One of the effects that they have is they actually block the metabolism of serotonin. Okay, so you take all the tryptophan and you're trying to make serotonin, your serotonin levels are low, and you keep taking stuff to try and get your serotonin levels up, and it turns out that you have a Clostridia infection of some kind. Okay, so correcting the dysbiosis and the Clostridia will actually help to improve mood, okay, which is huge. So I want to talk briefly here about biofilms, and I'm sure many of you have heard about biofilms. Biofilms are communities, right, of microbial cells surrounded by a polymer, right, or an extracellular type of substance, right? In other words, it's a wall. And we call this EPS, okay? They can be composed of single or multiple organisms, including both aerobic, anaerobic, fungal species. Lyme creates biofilms, right? Newer research is showing that viruses can create biofilms. And so in lay terms, what they do is they kind of build this little house around themselves with the same stuff that crab shell is made of, and they hide out in there. And as they hide out in there, they can kind of talk to one another. They can operate as a unit, right? And you can see that point 3 there, they communicate via quorum sensing. So quorum sensing is them communicating with other biofilms, communicating with each other. And essentially what happens is they evade the immune system. And the last point here, more than 80% of microbial infections have developed biofilms beginning in as little as 2 weeks from the onset of infections. So biofilms are a huge, huge problem. And especially when we look at the next slide here, right? Look at this. Biofilm bacteria can resist up to 5,000 times the antibiotic concentration that would normally be needed. So we are entering a stage here in our evolution where we are scrambling to figure out new antibiotics, and they are not being researched and they're not being developed. So we got a lot of drug-resistant bacteria now, and biofilms are making up about 80% of that. Okay, so biofilms in the GI tract often contain something called LPS, endotoxin. We'll talk more about that in a minute. Intestinal permeability can translocate the LPS to other parts of the body, and biofilms are associated with many chronic diseases. You can see their lungs, ears, oral cavity, GI tract, joints, brain health, okay, and so on. And they're very, very difficult to test and diagnose. So the 5 stages here, we have this initial attachment stage. We then have irreversible attachment, different stages of maturation, and then dispersion. So what you'll see in that, in the 5th one there on the far right-hand side of your screen, this is where the levels build up, right? The organisms grow, and then they escape and off they go into the bloodstream. This often manifests as flare-ups, okay, in people, especially those people with autoimmune issues. So when to suspect biofilms, because we can't really test for them, if you have chronic persistent infections and or health conditions. So here we see tonsillitis, otitis media, sinusitis, chronic dysbiosis, chronic cystitis, and any kind of periodontal disease, right? So gum and tooth disease. Cycling between flare-ups and asymptomatic periods. And if antibiotics provide little or temporary relief, that's where we might want to suspect that these people might have biofilms. Okay, so there's different types of bacteria that are involved with biofilms. We've got E. coli, Staphylococcus aureus. I'm not going to try and pronounce all of these, by the way. Pseudomonas, Streptococcus, Klebsiella, and so forth. And you can see I've put in brackets. These are involved with certain, very common issues that we see in clinic. So UTIs, we can see Staphylococcus aureus here, skin, psoriasis. So much research with Staphylococcus aureus and psoriasis. Pseudomonas here with pneumonia, cystic fibrosis. We've got the Streptococcus here with dental plaque, and Klebsiella, UTIs, rheumatoid arthritis, and dysbiosis. Okay, we'll see this is a very common autoimmune trigger. Many of these are included in stool test biomarkers. How convenient, right? So we can actually see what's going on in the gut, and then does this person also have rheumatoid arthritis? Do they also have psoriasis, and so on and so forth? Okay, how powerful is that if we correct the dysbiosis and resolve these infections, all of these other things that are unrelated will also improve, okay, which is huge. So quick note on LPS, if no one's heard of LPS before, this is, by some people's standards anyway, this is the most inflammatory compound known to human beings. Okay, it is a component of biofilms. It's also on the outer cover of these gram-negative bacteria, and this is a major factor in pretty well all autoimmune diseases. Okay, we'll see also Alzheimer's, chronic fatigue, fibromyalgia, and so forth. And the last point is really the take-home point here. LPS can pass from the gut, right, and the oral cavity, and actually go into anywhere in the body and setting up the stage for inflammation, for autoimmunity, and so forth. Okay, so so more on that in just a second. Look at this list. When you look at GI biofilms, endotoxins, and chronic disease, I mean, look at the wide array of illnesses here. The immune system side of things, autoimmunity, weak immune response, inflammation, central nervous system, mental health, anxiety, aggression, etc. The endocrine system, how many people walking around with Hashimoto's or autoimmune thyroiditis, adrenal issues, and so forth, and not suspecting that there might actually be GI infections and biofilms going on. Blood sugar issues, joints and muscles, and GI tract, right? There's a whole host of things that are going on here. So I want us to start thinking a little bit differently here about how we redefine our understanding of the microbiome and infections. Okay, I've come to this very different realization in the last 2 or 3 years. And there's always been this idea, this question, right, of what happens to the good beneficial organisms when I'm trying to get rid of the infections. Okay, so what happens to them? I remember years ago working at Whole Foods in Canada, and there was very, very scant research, and someone was selling oregano oil. And we said, what does the oregano oil do to lactobacillus and bifidobacterium in your gut? And the research that they had said it did nothing. Okay. I think that it does something for sure. You can't just go in there and wipe out the bad guys with no consequences. So I've developed this sort of concept, if you will, called Symbiome. And we actually have a group gut health program that's getting launched very soon by the same name. And it's appreciating the symbiotic relationship between all of these organisms, including the opportunistic ones as well. Okay, because when we look at things, right, dysbiosis is simply a symptom of other underlying problems, right? These are systemic problems. That could be poor digestion, as we discussed earlier, poor diet, low fiber, excess sugar, low dose antibiotics, glyphosate, pesticides, a favorable environment for dysbiosis. So the question is, if we've got all of these infections going on, do we just go in there, guns blazing with antibiotics and antimicrobials and just whack them over the head? Well, what if you have low beneficial flora? What's that going to do, right? So we'll come back to this concept of symbiome and the symbiotic relationship in just a minute. All right. There's problems with long-term restrictive diets. How many people do you know go on a low FODMAP diet and never get off? Okay, and I'm curious, or a Candida diet or a low carb or whatever. How many people, how many people go on these types of diets and they never ever get off? Has that happened to anyone? Okay, and just in the chat box, you can just and I'm looking at some of the comments. I'm going back here. So yeah, absolutely. I mean, I wish I had time to address all of these different points. But how many people do you know in your clinic, or perhaps yourself, you go on a low FODMAP diet, and then all of a sudden you try and open up the diet and boom, right? The gas, the bloating, the abdominal pain is still there, right? What about people going on, all right, I want to do a podcast on this soon. What about people going on carnivore diets? Or keto diets, for that matter. All right. So true, if I have SIBO, if I have Candida, if I have anything, yes, they feed mostly on carbohydrate type foods for sure. But let's not forget that our microbiome, the beneficial flora, also feed on carbohydrates. So in addition to starving out the pathogens, we're also starving out the good guys. And can you imagine running a stool test and you've got high Candida levels, for example, you've got low keystone or beneficial species, and now you starve all of them out. Well, what's going to happen is, you might, you might get the symptoms under control, but you haven't really corrected the underlying environment, the poor digestion, or any of that stuff, right? So really, we have to zoom out and we have to look at this problem in a different way. When you look at things like Candida, for example, Candida actually has certain benefits, believe it or not. One of the things that Candida does is it actually sequesters mercury in our body. So lo and behold, people with mercury problems, right, toxicity, oftentimes will have very high Candida levels. Well, what would happen if I came in there and I started wiping out all the Candida, but did nothing to remedy the mercury? That mercury could actually become a problem, right? It could settle in different tissues in your brain, anywhere else, and cause problems. All right, so it's very important to really look at these types of problems through a holistic lens, okay, and take care of the overall environment. Okay, so and thank you for your questions and your comments. I appreciate it. So this is exactly what we're talking about. So there's dysbiotic patterns, low keystone species and high pathogens. Low keystone species and no pathogens, or high keystone species and high pathogens. Each of these is going to require a slightly different approach, right? Very, very high level here. If someone had low keystone species and high pathogens, I might use a very, very short course of low dose antimicrobials, but I'm going to start really trying to repopulate. Okay, same thing with point number 2, low keystone species and no pathogens. For high keystone species and high pathogens, that's where I might go with a full course, maybe even 2 rounds of antimicrobials and then get into repopulation. Okay, we'll talk about that a little bit more as we move on here. And so this is where we want to really reinvent antimicrobial therapy. Okay, and this is where I'm at. I feel in some ways, and I say this with the utmost humility because I'm learning from other people, I feel like we're going to start to see this more and more, where the old school way of just going in and whacking it over the head with antimicrobials and then cleaning up the damage afterwards, I think that we're getting to the point where we can be a lot more subtle with our approach. We can be a lot more refined with our approach, and we can sort of use antimicrobials if and when we need them, but we can actually rely on strengthening, on fortifying the microbiome as a whole, okay, with diet, supplements, and lifestyle. So the key here is we really want to preserve the keystone species. And I know practitioners out there that will not use antimicrobials at all, which is kind of crazy to think. Okay. Now, I don't agree with it 100% because, I mean, there are aggressive infections where you absolutely have to use those. But nonetheless, we want to use antimicrobials as little as possible and only when needed. We want to repopulate as quickly as possible. Now, you can imagine someone with SIBO, if we start trying to repopulate too quickly, they're going to blow up, right? And this is where you get into the subtleties of what is going on with that person. Okay, but repopulating, rebuilding, we can use spore-based probiotic strains to crowd out pathogens. Some amazing research coming out on very niche spore-based strains, rapidly colonizing, right? And not only do they crowd out the other pathogens, get this, they actually help to lift up all of the other keystone species. Okay, so the idea of trying to match, right? So now, because this happens a lot on stool tests, I'll see that certain organisms are low. So what do? Naturally, I want to go and find probiotics that have the missing organisms and add those in. Well, sometimes they don't implant very well. They don't take root very well. And you'll find that oftentimes what I'll do is I will use those together with the spore-based strains. And I find that is rapid colonization and repopulation. Okay, we can also rotate strains as well so that we get a variety of different organisms in there. We can use immunoglobulins, so fantastic immunoglobulins on the market now. And these are amazing for mopping up microbial die-off. We can use them with binders as well. And really what that does, together with liver and gallbladder support, will help to minimize Herxheimer or detox reactions. Okay. Now you can see here, nowhere on this particular slide deck or slide do I have antimicrobials yet. Okay. Now, when it comes to disrupting biofilms, botanicals are incredible. You know, plant-based herbs, spices, stuff like that, they don't have as big of an impact as a lot of the very strong antibiotics and so forth, but that's kind of what we want, right? We want to use these low-dose botanicals to help things like inhibit quorum sensing, inhibit the attachment phase, the swarming. They have antimicrobial properties. We can also start utilizing flossing and oil pulling, right? And looking after the oral microbiome because it's going to prevent translocation to the gut microbiome. So a lot of these types of things we can do with herbs. Here we can see garlic, oregano, bilberry, bladderwrack, and golden seal all inhibit quorum sensing. This is established in the literature. Curcumin and quercetin can reduce metabolic activity of biofilms. Oregano, tea tree, galbanum, lavender, cassia, thyme are all essential oils that can prevent adhesion. So remember, when we discussed the 5 stages of biofilm formation, you know, we don't know what stage the person is in. It's very difficult to detect that. But when we start using broad spectrum formulations, we can kind of capture all of those stages. You can see thymol over there, which is found in thyme, black cumin seed, and other phenols will interrupt the initial attachment phase as well. We've got certain nutraceuticals here, so arginine, grapeseed extract, berberine, tannins, eugenol, NAC, EDTA, all of these are being studied with regards to biofilm. And the reason why I'm sort of banging on about this is we are entering that phase where antibiotics are not starting to work. And the reason why there's so much research behind this now is because people are looking for alternatives, right? And lo and behold, nature provides us with the alternative. We can use proteolytic enzymes, polysaccharide enzymes to help break down the outer shell of the biofilms. And then we can use immune supporting compounds. Medicinal mushroom, shiitake is amazing. Echinacea, immunoglobulins we spoke about before, colostrum, and even homeopathics to help to retrain and strengthen the immune system. So in terms of a general framework, just to bring us into the close here, okay, I know this is a lot to digest. It's a lot to take in. I totally get it. But if I can impart anything with you, it's just start thinking differently about how you approach this stuff in your practice. So we can observe the 5R approach. So this is remove, replace, repopulate, repair, and rebalance. This is current standard practice that is being taught by all of the labs out there. I think this is going to start to become a little bit outdated sooner than later. Okay, but remove and repopulate are really the two phases there. We can do antimicrobial therapy followed by repopulation. I would say this is a good point of call or protocol here for aggressive infections, for things that have, a lot of symptoms. You can go with the antimicrobials followed by repopulation. We can go with antimicrobial therapy together with probiotics, prebiotics, and so forth. Again, if you try and do that too early, you're really going to stir things up. So again, you have to take that on a case-by-case basis. And for mild dysbiosis, we can avoid antimicrobials altogether. We can actually crowd out the bad guys, the pathogens, with probiotics, prebiotics, diet, and lifestyle. Number one rule here is don't try and fix everything at once. Okay, don't try and fix everything at once. Right? Because you're going to overwhelm yourself, you're going to overwhelm your client or patient, and you're just not going to be able to do that, to be honest with you. It's almost impossible. So if it took someone 40, 50, 60 years to get where they are, it's not going to take them 4 weeks to get back. Okay, it's going to take them some time. And when you tee it up like that and you set up what I call the wellness roadmap, what you're going to do is work on this in increments. And I tell you what, in 3 or 4 months, you can get a lot done, even with the most stubborn infections out there. Okay, when you take these types of approaches. So that's it from my side tonight. What I do want to share with you before I hand it over to Q&A is we are open for registration and enrollment right now. This is a continuing education program. This is my program, and we sort of brought that into the fold with IHN and their ConEd, Digestive Health Practitioner Masterclass. And just to give you a sense of what is coming up in that program, this has been going on for, I think it's my 3rd year. So we've been running this for 3 years. And I know that some of you that are in that program right now are actually on that webinar. So if you have anything to say, I'll leave you to the chat box. But the feedback has been amazing so far. And what started out as a workshop has really morphed into a masterclass, a true masterclass. So we're starting June 20th this year. I think orientation is June 16th. So that'll be 5 weeks of live online training. I'll say 40 plus hours of pre-recorded content as well to supplement the live classes. And then lifetime access, there's a whole bunch of stuff. So that's included with that. You've got meal plans, you've got food lists, quick links to functional lab tests, therapeutic dosage. And then what we've done as well as part of this partnership is I'm also going to include 2 bonus live Q&A sessions. That'll be after we've wrapped up everything. And you are also entitled to 25% off select IHN continuing education courses. So that's other courses as well. You will get a certificate of completion. And we do have a special offer for people who are IHN alumni. Okay. So Anna, are you there? Because I'm going to do this and take it over to the Q&A.
No, that was so good. That was such an engaging, amazing talk, Brett. Thank you so much. And I know that everyone here enjoyed it immensely. I can tell from the chat box. And I mean, there's just so much to unpack there, like you said. And it goes to show you, like, everything comes back to the gut. Like we say in Ayurveda, right? Everything begins and ends with your gut.
It's true. And, this is the thing, right? This is not new information. I feel like now science is just validating what Ayurveda and Chinese medicine have known since the dawn of time, which is really cool. So very exciting. Yeah.
Yeah. Thank you so much for that talk. That was just fantastic. I want to watch it again, even though I've done Brett's class. I could watch all of this all over again. I take notes and then I read them, and the videos in the group too are great. A lot of the ones you've posted as well, like the recordings.
Yeah. So, awesome.
Yeah, it's excellent. So let's get to the Q&A. We have some questions and I can start off for you. Lots of great comments in the chat, Brett, from other people that are in
Thank you. Well. And it's good to see some of you as well. I haven't seen some of you with everything that's been going on over the last while. I haven't seen you in person. So, it's good to see the names, and I can't see all the faces, but I hope you're all doing amazingly well. Okay.
All right. So we'll start with the first question. It says, Brett, can you speak to hidradenitis suppurativa?
Oh, yes, I can. Oh, my gosh.
He says, is the root cause an infection or something else? It's very hard to find much information on it.
It's very difficult. So first of all, I cannot pronounce it either. I just, HS, I think is what I call it. I've had a number of clients come in with that. For those of you who don't know what that is, it's basically you get these very painful lesions, oftentimes under the arms, to the point where the skin can crack, it can bleed, and so forth. It's a very, very painful skin issue. There is a huge autoimmune component to that, but there's not one root cause, right? So bacterial infections are definitely present. Sometimes they can actually be on the skin microbiome. So I found some natural topicals that have colloidal silver that really work quite well. I find that you really need to approach that from a holistic perspective. There's usually digestive issues going on. There could be food sensitivities going on. Those people often consume a lot of sugar. So there's a lot of things there. I would say there's about 5 or 6 root causes that I usually look at with that. But detoxification is key, because you got to get the inflammation down. So the main thing is identifying what is the cause of the inflammation, removing those triggers, and then kind of proceeding from there. But I'm not going to lie to you. It's insanely difficult, right? And I know because I've spoken with other doctors about it. No one's figured out the magic sauce for that one.
Wow. Okay. Next question from Sabine. Can you comment on H. pylori, please? Would it be something that needs to be treated first before you can get rid of other infections? How can you differentiate between, for example, H. pylori and SIBO without testing?
Wow, lots to unpack there. So first of all, it's a great question, because that is an ongoing debate in the community. There's 2 schools of thought, right? One is doctors will say if H. pylori comes up on a test, treat it regardless. You got to go with triple antibiotic therapy. Bam, done. End of conversation. Then there's the other school of thought, which I sort of subscribe to a little bit more, is are the symptoms present? Does this person have an ulcer? Do they have acid reflux? One of the cool things on a GI map is you can actually there's H. pylori, and then there's what are called virulence factors. And so virulence factors basically will show you how that particular strain of H. pylori might manifest in the person. So what symptoms might it cause? And let's consider that I would say about 40%, if not 50% of the global population has H. pylori, and most of them don't have any symptoms. So again, I defer back to Missing Microbes and Martin Blazer's book, because he's actually an H. pylori specialist, and what he's found is that H. pylori actually suppresses and helps us in the long term. So it can help to sort of shut off certain types of cancers and other issues as well. So I think, again, I don't think we should be going in there willy-nilly and just blasting H. pylori for no reason. And some people would absolutely disagree with me on that. Now, I think if it's producing symptoms, then for sure you should treat it. And here's something really cool. Just came on the market right now. I cannot remember the name, but there's a specific probiotic strain that actually binds to H. pylori. Probiotic strain that binds to H. pylori. So I'm interested to try and start using that in my own practice. It's brand new. It literally came on the market in like the last 3 weeks. So to your second question, you're not going to be able to differentiate between H. pylori and SIBO or any other infection for that matter without testing. Obvious ones, SIBO, again, I go back to those SIBO checklists. If people are checking off a lot of those boxes and then they also have symptoms, I can put my best foot forward and say, yeah, you probably got SIBO, right? But the symptomology between H. pylori and SIBO are quite different. And that is because the H. pylori is in the stomach. Okay, SIBO is in the small intestine. So they're going to manifest quite differently in that sense. Okay. So hopefully that answers your question. There's a lot more to unpack, but I digress. Okay.
That's for sure. There's a lot to unpack there. From Gina, when people come to you with an extensive food sensitivity list done by an ND with a galvanometer,
so
do you use that, or can you recommend a more concrete food sensitivity test?
Well, how long do we have? The food sensitivity testing is another quagmire. So what you're talking about is electrodermal screening. So for those who don't know what that is, sometimes called a meridian stress assessment. It's where you have the electrodes and then the person they've got the electrode and they kind of do this and they run through different frequencies. I found those to be very erratic. They're also very, very sensitive. And what I mean by that is because they're so sensitive, they can often pick up things that are not actually problematic to the person. They're very much in the background. And so I've had people that will come, if I do an IgG test or if I do a full IgG, IgE and complement test for 300 foods, and I do an electrodermal screen for the same 300 foods, you're going to find that sometimes 200 of those foods will show up on an electrodermal screen. And the problem with that is that people start cutting foods out that they don't actually have to cut out. Okay. That's a huge problem. And again, you paint yourself into a corner and then people get afraid. And so I don't have a lot of time to get into it all here. Suffice to say that, if you start looking at things like LCAT testing, if you start looking at ELISA, LRA testing, those are really gold standard in terms of tests. But the problem with LCAT testing, they're very similar. What I like about them is they actually challenge your immune system and they tell you what your immune system is sort of reacting to right now versus simply measuring antibodies, which can be good or bad. Antibodies can just be there. They can be protective or they could be causing problems. And that there is the murky, murky world of food sensitivity testing. Okay, so I'll leave it at that for now. Yeah.
Okay. All right. From Sabine, I heard from several NDs that they are moving away from the GI map test. Have you heard about that?
With any test, right? So there's people moving away from GI map. There's people moving away from GI effects. There's, I think that if you still look at a lot of the top clinics out there, they are still using GI map. Is it problematic? Sure, there's going to be problems with any test. But, it also depends on what you're looking for, right? So if you're looking for something, like a GI 360 or a GI effects from Genova, those are also good tests, but they run on very, very similar technology. So I think what you find is, you might find a few people have said, oh, well, we tested it against this other test and this other test is better. Therefore, GI map is terrible, right? And we're all going over here. In actual fact, it's not terrible. Maybe they just found something that works better for their situation. Okay. But I can tell you that a lot of the top functional medicine clinics in the world are still using GI map and not as their standalone test. Even for myself, I've got about 3 or 4 tests that I will use depending on what I'm looking for. Okay.
Okay. Pinalban is asking, can we order these tests, which is something you go over in.
Yeah, so I go over that in the masterclass. I'm constantly talking to labs and working stuff out in the background. So the short answer is yes, there is a way. And also I'm pretty careful as well in terms of, the tests that I do, just generally speaking in clinic, I avoid blood draws altogether, right? I don't do any blood draws because you really are stepping out of scope. So if you're doing skin prick, if you're doing, even skin prick's a little iffy, but stool, saliva, urine, you're good to go, right? You're not collecting anything. Your clients are collecting that. You're not diagnosing any disease and so forth. Okay. So short answer is yes, you can order pretty much all of these tests.
Yeah. And I did that organic. went to Great Plains because of and you can do like a weekend, you pay them. It was like $225 US.
And you get a test. Yeah.
Organic acids test. And then you have access to these live teachings, these live people talking about it, teaching you how to interpret them. It's a lot. It's hard work.
Oh, it's 8 hours of organic acids testing.
But they give them to you for like 30 days. I didn't go to it again, but Great Plains is really good.
Yeah. They've been around for a long time. Yeah.
I use them, and then I ended up asking, because you get that, I think it's a 30-minute consultation with a specialist there when you have the test. So that'll help you if you have a client you want to know something, right?
Yeah, yeah.
Recommend that. Okay, so Alyssa asks, what about colloidal silver for biofilms? Is it too strong from an antimicrobial standpoint?
No, not at all. I also, you got to, like biofilms, there's no one trick that's going to work for every single person, right? Because biofilms are not static. They're also not composed of the same thing. So, if you got a biofilm on a heart valve or a biofilm on a catheter or a biofilm in the GI tract, the actual makeup of that biofilm is going to be different. Right. So there might be a combination of, like, one might have Lyme, for example, whereas another one might be fungi and bacteria. You can have biofilms that are single organisms only. Right. So there's no real, and truth be told is, you have to break down the outer shell of the biofilm. So what I'll find sometimes is when you start working like that, you'll kind of, if you crack that biofilm open too quickly and the person hasn't been prepared properly for detoxing, they're going to have crazy reactions, right? And this is why part of what I teach in the masterclass, one of the sort of pre-recorded modules, is all about preparing for detoxification. And so we talk about how to kind of ease people into that, how to tee it all up so that you're not just going in session one, antimicrobials, because how many people, I'm sure many of you on this call can relate to that. You start off session one and it's too much. Your clients aren't coming back. They're having crazy reactions, right? So we can set it up so that doesn't happen, which is good.
Okay. I've tried everything to reduce my headaches and migraines. Could they be caused by gut microbiome imbalances?
100% they can. Yes, absolutely.
Okay, Amanda, can a positive SIBO test of 111H2 be incorrect and or be confused with Candida or parasites?
Short answer is no, it's not going to be confused with anything. However, you can also have what are called co-infections, right? So it's quite common to have SIBO and SIFO, and you can have a parasite. So you can have all three of those things going on at the same time. The most important thing when you're looking at a SIBO test is to look at that 120 cutoff, right? So if you're doing a 3-hour SIBO test and your peak of 111 is crazy high, by the way, but a peak of 111 after 120 minutes is actually going to be more indicative of dysbiosis in the colon. Right? Because you normally produce a lot of hydrogen in the colon anyway, but once it starts really going up like that and you have the signs and symptoms, you might not be dealing with SIBO, you might actually be dealing with colonic dysbiosis at that point.
So interesting. Okay. If anyone changes their diet, how long should they continue?
Oh, that's a loaded question because it really depends on what you're dealing with, to be honest. Yeah. And also the supplements are going to sort of enhance everything as well, right?
Absolutely. Does the GI map have H. pylori on it?
Yes, it does. Yeah.
Just to add to the H. pylori question, if there's time, person doesn't really have the common symptoms of H. pylori, but keeps testing positive for it. Doesn't really get anywhere with antimicrobials. It's been a while now on It's been a while now on various natural protocols. Is there a specific time when you would agree with going on antibiotics? I know it's a loaded question.
Well, let's put it this way. If you want to get the job done, triple antibiotics work. Okay, they work. They're very aggressive. They work. The question is, again, I come back to 40%, so 50% of the global population have H. pylori. It's passed down from their parents to the kids. Do we want to be getting rid of it? And again, there's a lot of debate that's going on there. So, I will also say this, that H. pylori is very, very stubborn. Okay, it's a very stubborn thing. So even if the person has lots of symptoms, it can be very problematic. And I would say, I'll go out on a limb here and say that I usually reserve antibiotics as a last resort. Okay, so for example, and I know we're talking H. pylori, but I'll talk about SIBO for a minute. If you look at SIBO, there's certain people will respond to the diet, others will not. Certain people will respond to herbal antimicrobials, others will not. And certain people will respond to the antibiotics and others will not. So sometimes what I've had to do is say, okay, let's go on the diet. Well, we didn't get anywhere. Okay, stay on the diet. Let's go with the herbal antimicrobials. Well, we didn't get anywhere. Maybe it's time for antibiotics. And, antibiotics are strong, they're quick, they're dirty. It's 14 days of rifaximin and boom, your SIBO symptoms are going to be way down. But that's where, again, it's time and place, right? Depending on what you're trying to do.
Yeah.
Okay,
from Gina, would you do a SIBO breath test to determine which type of SIBO a client has? If a client has a GI map test that was done 9 months ago, I'm not sure if that's making sense.
A lot can change in 9 months, and especially if you've actually been doing active work on yourself. So if symptoms haven't resolved, you might want to look at a SIBO test. The main thing is always go and check the symptoms first. That's really the most important thing is like, do I check off all the boxes for SIBO? Is it a strong, do I have a strong case for testing SIBO? And, if you want to just have a look, sure. Like, hey, I run tests on myself just to experiment, just because I want to see what's going on. Right. So annually I'll run a stool test, and then, I'll run a different stool test the next year, and I'll run organic acids testing and whatever. And that's more just me figuring out, myself. Yeah. But I would say, for people that are coming into the clinic, do I just want to randomly go, well, you got gas and bloating, we should probably run a SIBO test? No, that's where I want to sit down and actually go through what are they reacting to, what are the signs and symptoms, and then sort of go from there. Okay. So hopefully that helps. But I also wouldn't necessarily, unless you're really good at interpreting GI maps or Biome Effects for that matter, I wouldn't draw the SIBO conclusions from the stool test. Okay.
He says, would the breath test be critical for the protocol planning?
For SIBO, yes, it can be. And again, for me, I'm coming up on 18 years, actually. My bio's outdated. But, after so many years of seeing these types of things and running hundreds of tests, you can start to get good at seeing certain patterns, and you can draw some conclusions based on experience. But for people just starting out, the difference in treatment, for example, methane SIBO, methane-driven SIBO is very, very stubborn. It doesn't respond to a lot of things, and this is what causes constipation. So you need a very specific type of treatment plan for that type. And hydrogen sulfide is a completely different animal. So even a low FODMAP diet's not going to work with hydrogen sulfide. So, there's a lot of nuance when you talk about things like SIBO. And honestly, I had Dr. Jacoby on my podcast. She was one of the first guests on my podcast when I first started. And we spoke about SIBO. And even before I got onto the podcast, I was like, what's the big deal with SIBO, right? Everyone's just like, whack it over the head with some antimicrobials and boom, we're all done, And it's like, no, there's a lot more nuance and texture to the conversation there.
Okay. From Sabine, did you say that the Missing Microbes author is also the one very knowledgeable in H. pylori?
Yep. He's actually, I think he works at NYU, and he's been researching, he might even be retired now, he's an older guy, but he was researching H. pylori for the better part of 30 or 40 years.
Okay. I'm just checking to see for...
Yeah, all good.
Any more questions? Gut issues and hair loss, are they related?
They can be, for sure. Yeah, absolutely. And, there's a lot of other things with hair loss. You've got the hormone side of things, thyroid, you've got iodine, you've got trace mineral deficiency. So there's a lot of other things. Hormones generally, even androgen imbalances can cause hair loss. Inflammation. There's a bajillion different things that will tie into that. But short answer is yes, gut health can absolutely be tied to that, for sure. Yeah.
How about rifaximin? Is that how you say it?
Rifaximin, yeah.
Or SIBO, short-term, long-term.
Yeah. Well, one of the cool things with rifaximin, in terms of if I had to pick an antibiotic that I would happily take, because I'm not opposed to antibiotics when they're used correctly, but rifaximin is one of those ones that doesn't become systemic, which is pretty cool. It's one of the only antibiotics that stays localized to the gut, which is cool. So when you take it, and you can double down with herbal antimicrobials as well. But, what's interesting is they've actually done studies on rifaximin versus herbals, and the herbals actually work just as well, if not better, than the rifaximin. So I usually, I will whisper in people's ear and sort of say, hey, maybe you want to talk to your doctor about rifaximin. I'll usually do that as a sort of last resort. But, if you want to just get the job done, rifaximin can work for a lot of people. I found, though, in my experience, I've had a lot of people that have gone the rifaximin route and they relapse quite quickly, because the relapse rates for SIBO are 3 weeks. In other words, if you don't follow through with the whole plan, you can be right back to square one in as little as 3 weeks. Okay, which is kind of crazy. Yeah.
Okay. In your practice, what has been your experience dealing with rosacea?
Rosacea, same thing. Like, I don't like to pigeonhole anything, right? And, people always come with like what disease or what illness. It's like, just zoom right out and look at it from a holistic perspective, so why is it rosacea? You want to be evaluating androgens for sure. There's inflammation going on. You can absolutely have food sensitivities and GI inflammation that are driving that as well. So instead of, treating it and what's the best cream or lotion or what have you, heal from the inside out is really the way to go. And I just look at everything. There's always going to be multiple roots, right? Or multiple root causes for anything. And so that is going to be different. So, if you take a disease in one person and the exact same disease in another person, there's going to be commonalities, but you might find that the actual origins are going to be slightly different. And that's where, going down the holistic route, you can actually uncover things and work on them in a much deeper way.
Cystic acne related to parasites or bacteria?
It can be. Again, I come back to hormones. There's toxicity as well. Inflammation is a big one with cystic acne, for sure.
Okay. And here we go. When you have low HCl, SIBO, and poor liver pancreas function, which do you treat first?
It's a difficult question to answer, because, you really have to look at the person themselves. There's no, I'll say this again, there's no, when I talk about, giving people protocols, right? And I say this in the masterclass, one of the first things you'll hear if you join, I don't give people cookie cutter protocols, okay? Because I don't believe in them. I don't use them. However, to have a rough template and a framework to start from and have that ironed out, and then sort of say, okay, now this person is showing this, that, or whatever. Now you can sort of tailor that and really make it personalized and customized. And so, I don't have a good answer for you. I would say you could work on all of those things. However, if you've got SIBO, for example, and gallbladder, you might want to get the bile flowing and you might want to get the SIBO under control, because the HCl is going to take a lot longer to repair. SIBO you can have under control in 4 weeks. Low HCl, like if the person's stuck in fight or flight or whatever, or they got nutrient deficiencies, it's going to take you a while to get that sorted out.
Wow. I think that is possibly the end of
cool.
It was awesome.
All right. Good stuff.
Brett, thank you so much.
Thank you. Thanks for having me.
It was so enjoyable. I love doing these. So I hope everyone, Brett's seminar, his Con Ed class starts June 20th. If you have any questions, reach out to Brett, reach out to myself.
Yeah, sure.
In the program, if you want any feedback about it. And I think a couple of people are asking about IHN discount. I believe that's on the website.
It's all on there. Yeah, you can just click through to the website. Everything's on there. And what will happen is if you go to the IHN website, eventually what will happen is you'll land up on my site. It's just one click and you're on there. And that's where registration and all that stuff, all the details are on there. Okay.
Perfect. There's a million thank yous on the chat box.
Thank you all. Thanks for showing up. It's great. I know everyone's busy.
The rest of your evening, everybody. Thank you, Brett, and we'll see you and talk to you soon.
Okay, awesome. Thanks, everyone. Have a good night. Okay, bye.